So now we're going to talk about some of the symptoms of motor neuron pathology. We talked a little bit about how the motor neurons work and how they're working with the spinal interneurons. And now we're going to talk about some of the signs and symptoms of motor neuron pathology. So I want you to be able to define some of the symptom names: atrophy and fasciculations. And fibrillation should be on there as well. It's probably in the next lecture. In the exam study guide, it has them all listed together, but for the lectures, I separated them out to which lecture they're in, so hopefully that makes sense. And if it doesn't, tell me in office hours and we'll figure it out. But I want you to be able to define paresis and paralysis and what's the difference between the two. And then what signs and symptoms would you expect to see if a lower motor neuron was destroyed and the muscle was completely denervated? Okay, so let's talk about it. Involuntary muscle contractions, one that we've probably all experienced, are muscle cramps. Muscle cramps are severe, painful muscle contractions lasting seconds to minutes. They happen to everybody. Something like 99% of people experience muscle cramps at some times in their life. And lots of different things cause muscle cramps. Sometimes you can cause a muscle cramp just by contracting a two-joint muscle across both joints. And you can cause yourself a muscle cramp. They can also be caused by other things like electrolyte imbalances and pathologies. So that's just muscle cramps. Everybody has them. Fasciculations are quick twitches of all the muscle fibers in a single motor unit. So the muscle contracts and relaxes, contracts and relaxes. So it's a twitch of fasciculation. Myoclonus is a brief involuntary contraction of a muscle group or muscles. So you can almost think of myoclonus as one and fasciculations are a bunch of twitches. So myoclonus is one twitch and fasciculations are several twitches. And these are all normal things. So I have it sort of separated into normal and pathological. So muscle cramps, fasciculations, and myoclonus are all normal involuntary muscle contractions. When we start talking about abnormal involuntary muscle contractions, sometimes abnormal movements and muscle contractions are generated by dysfunctional basal ganglia, and we'll talk about the basal ganglia in a couple lectures. Fibrillations are random, spontaneous, brief contractions of single muscle fibers, and they're not visible on the surface of the skin, as opposed to fasciculations, which often are. You can see the muscle twitching. With fibrillations, you can feel them, you can sense them, but you cannot see them on the surface of the skin. Tremors are involuntary rhythmic movements of a body part, and we'll divide tremors up a little bit more in a couple slides. So fibrillations are always pathologic. Fasciculations are normal, fibrillations are not. It's that random, spontaneous, brief contraction of single muscle fibers not visible on the surface of the skin. It occurs when a muscle membrane is unstable because of denervation, trauma, or an electrolyte imbalance. So fibrillations are not normal. Fasciculations are, but fibrillations are not. Tremors are involuntary rhythmic movements of a body part. Physiologic tremors can be enhanced by anxiety, stress, fatigue, certain medications, metabolic disorders, caffeine, it's like your hands shaking, or alcohol withdrawal. Resting tremors are when a person is not intentionally moving. So you're just resting and your hand is tremoring. Postural tremors occur when a body part is maintained against gravity. So if you're trying to hold your arm up, one time I did this workout that included about a zillion push-ups, and I tried to lift my coffee cup and my arm was shaking. That's a postural tremor caused by too many push-ups. An action tremor is when someone is intentionally moving. So you're trying to do something and you get a tremor during that intentional movement. So you can have non-pathological tremors caused by all these different things, but you can also have pathological tremors. In Parkinson's disease, it's typically a resting tremor that affects mainly the hands and the lower limbs. So a lot of times people will have what they call a pill rolling action where their fingers are sort of moving together only at rest. Then when they go to do something, the tremor reduces. Cerebellar tremors are usually intention tremors, so the tremor increases when you go try to do something. And psychogenic tremors are characterized by sudden onset and remission. So all of a sudden you have tremor and then it goes away. With Parkinson's, it's usually resting and it goes away when you do something. And cerebellar, it's there when you do something and it goes away when you rest. Because the motor neuron is the only route from the spinal cord to the muscle, motor neuron lesions interrupt efferent limb reflexes. So when they're testing limb reflexes, a lot of times they're looking for nerve injuries. So if you have a decrease or loss of reflexes, it could be because of a peripheral lower motor neuron lesion, because we've interrupted those efferent limb reflexes. So I was talking about the guy who had diminished reflexes in his injured biceps tendon, or his injured biceps, and then when it got better, he had improved reflexes. So the lesion was healing and it improved his reflexes. So paresis and paralysis are the loss of or decreased ability to generate muscle force. So paresis is decreased generation of muscle force, and paralysis is an absolute loss of muscle force. And it's common with lower motor neuron lesions. The complete lesion of a peripheral nerve produces paralysis because those motor neurons are the only pathway from the central nervous system to the skeletal muscle. A partial lesion of a peripheral nerve can produce paresis. So paresis is decreased ability to generate muscle force, and paralysis is the loss of ability to generate muscle force. Okay, so that's the difference. Paresis is sort of like incomplete, and paralysis is complete loss. You should know the difference between the two. Muscle atrophy is loss of muscle bulk. So you can get loss of muscle bulk from disuse. So you say that you just stopped working out and you sat on the couch. Your muscles would lose muscle bulk just because you're not using them. Neurogenic atrophy is caused by damage to the nervous system. So if the lower motor neurons are damaged, the muscles aren't getting stimulation from the lower motor neurons, and you get neurogenic atrophy. So it's not just plain old disuse atrophy, it's neurogenic atrophy. Different signs of motor neuron lesions. If the lower motor neuron cell bodies in the ventral horn of the spinal cord or the axons are destroyed, the affected muscles are denervated and they undergo decrease or loss of reflexes. We talked about that already. Paresis or paralysis, neurogenic atrophy, decrease or loss of muscle tone, and fibrillations, those pathological fibrillations. So those are the signs of motor neuron lesions, lower motor neuron lesions. You should know those. And then we'll talk about them with regard to specific pathologies. Motor neuron lesions cause two types of abnormal muscle tone. If it's just the lower motor neuron that's affected, you get hypotonia, which is abnormally low muscle resistance to passive stretch, or flaccidity, which is total lack of muscle tone. Sometimes you can have flaccidity immediately after an upper motor neuron lesion, but usually flaccidity and hypotonia are associated with lower motor neuron lesions. Okay? And then we'll talk about the upper motor neuron effects in a little while. So there are two types of electrodiagnostic studies that are performed on lower motor neurons: motor nerve conduction studies and electromyography. So motor nerve conduction studies are used in motor disorders to differentiate among three possible sites of dysfunction: either the nerve, the neuromuscular junction, or the muscle. So it's important that we know what part is affected, right? If it's a problem with the nerve, there would be one type of treatment. If it's a problem with the muscle, there'd be another. And if it's at the neuromuscular junction, there would be a third. So in motor nerve conduction studies, the skin over a nerve is electrically stimulated with an electrode, and the potentials, the electrical potentials, are recorded from the skin overlying the innervated muscle. With electromyography, the electrical activity of a muscle is recorded from the skin overlying a muscle, and that's surface EMG. If you want to do a diagnostic EMG, it requires inserting a needle electrode directly into the muscle. And when you have that done, I've actually had it done, and it hurts. It's not intensely painful, but it's one of those hey, stop that things. You're just like, this is not something that you want to get done if you want to avoid it if possible. So myopathy is an abnormality or disease that's intrinsic to muscle tissue. Muscle electrical activity is recorded during muscle contractions and at rest using an oscilloscope and a loudspeaker. So they have you contract the muscle and rest the muscle, and they record the electric activity. And they're trying to tell if there's something actually wrong with the muscle tissue, or is it a nerve issue, in which case you would look at your nerve conduction studies. So lots of disorders can affect lower motor neurons. Trauma, infection like poliomyelitis, degenerative or vascular disorders, and tumors. All of those can damage motor neurons. Some people who have survived polio have post-polio syndrome. The symptoms of post-polio syndrome are muscle weakness, joint and muscle pain, fatigue, and breathing problems. Some people think that post-polio syndrome is normal age-related decline that is more obvious in people who've previously had polio. And these days, most people who've had polio are older people because we have a polio vaccine now, and everybody gets it, hopefully. And so all of the people that I've worked with post-polio syndrome are older people, because older people are the ones that had polio. And a lot of people who have post-polio syndrome, they actually do fine until something else happens. So I've worked with people who were going along just fine. They had their stronger leg and their weaker leg, but then something happened to their stronger leg, and so then they had to come into PT to strengthen. Most of them, because they've been going through this their whole life, they know exactly their limits and exactly what they can do. I like working with people with post-polio because they have a very good grip on what goes on in their body. And a lot of times they've been in therapy for years. They kind of know what to do. So a lot of times when I've worked with people with post-polio, it's because they're going along just fine, and then they have some sort of decline, some sort of injury to the stronger leg, or they had to have a hip replacement on the stronger leg, or they had a decrease in balance and they come into PT to help recover their balance. So you'll see people with post-polio. I think that in the future we're going to see fewer and fewer of them as the post-polio generation passes out. I think we're going to see fewer people with post-polio syndrome. That's just my opinion. So post-polio syndrome still is the most common motor neuron disease in the United States. And the exercise recommendation for people post-polio depend on how much strength they have. So if their strength is near normal and there are no signs of the reinnervated muscle units on EMG testing, then they can do heavy resistance training. Excuse me. If they have moderate weakness, then they can do submaximal endurance training. And if they have paresis, walking, stationary, bicycling, and swimming. Swimming is a great exercise for post-polio.